non-chromaffin paraganglioma. Once more, this is a question which is being asked by a synonym savvy English professor like examiner. So basically there are multiple names given for the glomus jugulare. One of the names is non-chromaffin paraganglioma. So chemodectoma, non-chromaffin paraganglioma, glomus body tumor, paraganglioma, glomus jugulare tumor, glomus tympanicum, glomus vagale, carotid body glomus tumor and carotid body tumor. They are the different very closely named and related sisters which you have to wed with. So there is a reason, doctor, the glomus jugulare is the one which would be the correct answer for this is what need to be remembered. Now zidovudine can be combined in fact with any drug, but certain drug profile combinations is not considered to be a very good combination. So zidovudine alone or it can be combined with a diadenosine and zalcitabine. It is a very well proven combination in the clinical practice. Similarly, lamivudine and zidovudine is used. And similarly, the combination of nevirapine and also the zidovudine is used, especially to prevent the vertical transmission of the HIV infection. These combinations are commonly used in a HIV positive pregnant woman is what need to be remembered. So there is a reason, doctor, the diadenosine, nevirapine, lamivudine definitely can be combined. So stavudine probably would have been the answer for this question is what I like to present. But if you have any further reference, let us know. So Bartonella bacilliformis typically leads to hematological manifestation of anemia called the Orrea fever. Now this question answer is little typical. Was there any case history given along with this question? Like a person donating blood found to be HBsAg positive. Simply HBsAg positive, what do you want to do? It was the?
What test do you want to do before starting chemotherapy?
Treatment, before starting treatment. Okay. Let us review what the gastroenterology pundits talk about this important scenario. The AASLD treatment protocol is one of the world's standard treatment protocol for evaluation protocol for the hepatitis B virus positivity. What they say is do HBsAg, HBeAg, HBV DNA as a baseline test at the end of 6 months of treatment and also at the end of the treatment. So that is the reason, doctor, HBV DNA will not score over that of the HBeAg. Basically both of them are the markers of the ability of the virus to proliferate and the viral load. So that's the reason they both become equally the good answers. Anyway, transaminases and liver biopsy are not the routine recommendations as what you know. So there is a reason, doctor, how to evaluate a HBsAg positive individual is HBeAg, anti-HBe, anti-HCV and also HBV DNA, even anti-HEAV also need to be done, is considered to be one of the common recommendation. But when do you want to treat? What is the indication? Every person positive for HBsAg need not be treated. So what is the indication for starting your treatment? Either interferon or lamivudine or anything. The conditions are, indications are, if the HBeAg is positive in a HBsAg positive individual, if the HBeAg is positive, plus the serum alanine transaminase levels is greater than twice that of normal level. That is indication number one. That means you have to do transaminase also, you need to do HBeAg also. Similarly, presence of the HBV DNA plus alanine transaminase greater than twice the normal also is considered to be a criteria for initiating the treatment in a HBV positive individual. Similarly, moderate to severe hepatitis if you do liver biopsy. That means even biopsy wise also it is an indication. And the presence of the HBV DNA plus proven cirrhosis. So these are all considered to be the various indication to initiate the treatment and to decide which treatment is better over that of the other is what need to be remembered. So I'm not sure like what was the intention behind asking this specific question. Now carcinoma cervix, let us talk about the human papilloma virus. The 6B and the 11 HPV are considered to be the low grade type of dysplastic changes will be found, and they will never lead to the development of invasive cancer. The HPV 16 and 18 are found in 50 to 80% of cases of high risk types and 90% of invasive cancers. 31, 33, 35, 39, etc., etc. until 82 is also considered to be one of the risk for the HPV There's a reason, doctor. 18 is implicated, 16. These two are most. 31 definitely, though it is a less common type, but 12 is never implicated. So that becomes the odd man out here. In carcinoma cervix, pain becomes a problem only when the invasion occurs. Hence, the pain is a late feature of the carcinoma cervix is what need to be fundamentally remembered. If the pregnant lady is presenting already with IgG antibodies to the rubella, that means she is immune to the infection, is naturally implicated. Now, let us go to the next question. Tennis racket cells, which are otherwise called Bierbeck granules, are the ones, rod-like Bierbeck granules, are typically intracytoplasmic inclusions which are seen in the Langerhans cells. Histiocytosis is what need to be remembered. Was the histiocytosis was there as one of the options? Then that becomes the answer. Now, heart failure cells are not seen in the liver, they are seen in the lung definitely. So, they are the hemosiderin-laden macrophages which are being found in the lung once there is a chronic passive congestion of the lung is what need to be fundamentally remembered. Papillary necrosis, one of the favorite topics of the examiner, is typically found in three scenarios. In the analgesic nephropathy, sickle cell nephropathy, diabetic nephropathy is what need to be basically remembered. Now let us talk about the near total laryngectomy compared to that of total laryngectomy. When do you want to do it for the laryngeal malignancy is one of the important questions. I will take a couple of minutes of your time. Most of the patients who are having the advanced stage laryngeal carcinoma, they are not the candidates for the traditional conservative surgery. So that is the reason generally total laryngectomy is the one which is a frequently required procedure without any conservation, because by the time patient presents, predominantly they will be in advanced stage. Some cases there can be near total laryngectomy requirement also. But what is the advantage of near total laryngectomy compared to total laryngectomy? In a near total laryngectomy, patient can speak by using his internal myomucosal shunt, and he will be requires a tracheocutaneous stoma in order to breathe. So retention of the voice definitely improves the quality of the human life instead of becoming a dumb individual. So whenever choice is there, we try to prefer near total laryngectomy, but the choice is given very rarely because most of the times total laryngectomy is required. So the near total laryngectomy, also called the Pearson's laryngectomy, is typically has got certain contraindications is what need to be remembered. Especially the patients in whom the interarytenoid or the post-cricoid areas are involved with the cancer. Similarly, those in whom both the arytenoids are felt to be diseased, they are also not the candidates for the near total laryngectomy. And if there is any extensive subglottic involvement, that is also considered to be a contraindication. And suppose he is already a smoker, already lungs were bad, after near total laryngectomy there is a chance of aspiration which can happen. So there is a reason they are also considered to be the undesirable candidates for the near total laryngectomy is what need to be remembered. So that is the reason, doctor, what was the question? Is it an indication or a contraindication? What are the contraindications? So to summarize, we have the contraindications that include interarytenoid, post-cricoid, subglottic area involvement, or if the both the arytenoids got diseased. Now let us look what our people have recalled. Free lateral arytenoids. Lateral, one out of the two. If both of them got involved, that is considered to be a contraindication. Interarytenoid plane involvement definitely is considered to be a one of the the literature says interarytenoid or the post-cricoid area involvement is a contraindication. And if the anterior commissure involvement is there, then what is that scenario? Generally, radiotherapy is not done for the anterior commissure involvement. If the anterior commissure involvement is there, that is the indication for the near total total laryngectomy is what need to be remembered. So now let us go to the next question. Guy's apraxia. So in this, what is the final answer is what we are looking at. Yes, I think if the lateral arytenoids are free, or even one out of them is free, unless both are involved, that is not considered to be a contraindication. Only when both of them are involved, that is considered to be a contraindication for the near total laryngectomy. So positively that could be an answer. Definitely interarytenoid plane involvement is considered to be the known contraindication. And if the anterior commissure involvement is there, it is no more an indication for near total laryngectomy, it is an indication for total laryngectomy. T3 is the advanced stage. Hence there also it is a contraindication for the near total laryngectomy. So the only place where still near total laryngectomy is not contraindicated would be if one of the lateral arytenoids is free and both of them are not involved, is what with our ignorance still we are blissful about. Now let us go to the next question, doctor. Guy's apraxia. Is it a question on the sexual perversions in forensic medicine, psychiatric question, or a ENT question? So that's what I was first thinking. So don't worry, this is a question equally bad for everybody. Somebody knows about it means either paper is leaked or he is the son of the vice chancellor. So there are only two possibilities. Anyway, let us reason it out. Basically, examiner also has given larynx, adenoids, rhinitis, tonsillitis, a wide range. He did not give allergic rhinitis, then non-allergic rhinitis. If too many things have been put, then it would have added to a lot of confusion. Basically, this guy's apraxia comes in a very important condition called empty nose syndrome, where the inner nasal mucus producing tissues, that is the turbinates, are cut off the nose, leaving the nasal cavities too empty, and that will cause a diminished capability to perform their ability to conduct and prepare the inhaled gases to the lungs. What is the general function of the turbinates? They prepare the air before it goes into the lungs. Otherwise, every hot air that we inspire can't reach the lungs. Some tuning is done by the turbinates. But the problem is, if there is any allergic and atrophic rhinitis which has developed, these turbinates typically become atrophic and they lose their ability to regulate that air. In this scenario, what happens is what is called as a empty nose syndrome will develop. Now, because of this empty nose syndrome, there are some problems which will happen. Certain physical symptoms like the shortness of breath will be there, and that annoying feel of the emptiness of the nose will be there. Certain speech problems where the nose is required, because when we talk, nose is required to contribute certain sounds, is the problem. Certain psychological symptoms like depression, anxiety, social phobia will be there, because the nose is not contributing, and certain abnormal twinge will come out. And finally, there is a difficulty in concentrating and cognitive impairment will be there. And when the cognitive impairment develops, it's called apraxia nasalis of the guy, is what is basically the underlying cause. There's a reason it has something to do with the nose. If you know that allergic rhinitis, then that would be the answer. Now let us go to the next question, doctor. Incidence is calculated by the prospective trial where the population is well defined in the denominator, whereas it can't be calculated by using a case control trial because denominator is not very well defined. Already this is our favorite question. Attributable risk is the risk difference, and risk ratio would be the relative risk. Which is more contributory? Talk about attributable risk, talk about the causation is what need to be remembered.